Welcome to a lecture on ventilation and perfusion lung imaging in nuclear medicine technology. My name is Mark Crosswaite, and I'm speaking to you from Virginia Commonwealth University and part of the Society of Nuclear Medicine and Molecular Imaging Technologists section programs that we've been putting together for our listening audience. Let's start off with lung anatomy, some very basic stuff, which I think most of you, if not all of you, really know, and that the lung is consisted of 5 lobes. And from an air standpoint, you've got the main stem bronchi that bifurcates down the levels of the bronchioles to lower bronchial to terminal bronchioles to the alveoli, where oxygen enters and carbon dioxide is exchanged. From the pulmonary artery standpoint, they bifurcate down to pulmonary arterioles till they eventually get to a terminal pulmonary arteriole, and they arrive then at the alveoli as capillaries, again allowing for the exchange of carbon dioxide and oxygen. Here's an example of that. You can see the pulmonary artery here, bronchioles, the alveoli, and little red areas here showing that the capillaries are actually covering the actual alveolus, or alveoli for plural. So there are 2 basic lung diseases that we want to appreciate and to evaluate, but only one that we really are most concerned about, and that is pulmonary emboli, or PE. In PE, when we give a ventilation perfusion lung scan, the ventilation portion really in general should not really be affected by any blood clot that is actually in the lung. So the ventilation normally fills in, as we see in this diagram here. However, when you inject little teeny tiny particles called MAA, macrogated albumin, that are tagged to technetium-99m, they go all the way down to the lower end of the arterioles, and then they get blocked, or they block the lower end arterioles. And then within that, if there is a blood clot here, as represented here as a red little area, then the particles cannot continue, and you end up with this wedge-shaped defect. We call that a mismatch, where it is cold in perfusion and hot in ventilation, classic for pulmonary emboli. On the other hand, what sort of sometimes interferes with PE assessment is what we refer to as COPD, chronic obstruction pulmonary disease. And the best example I have is what we see right here, where the ventilation is affected by disease in the bronchioles, which actually in essence could also affect the disease in the arterioles, which then might mimic similar matches in disease. Of course, this would actually make it difficult to diagnose if there was pulmonary emboli in the perfusion image. So where does PE come from? It comes from deep vein thrombi, as we all probably know. And deep vein thrombi is usually non-specific. You'll see leg swelling, redness, discomfort. The patient might have pain. The patient might be actually asymptomatic. But what we do know about DVTs is they break off from the lower legs or from the legs, and then they travel up to the lungs, where they get trapped at the arterial levels, as indicated earlier. One interesting study showed that a 5-year study where they evaluated patients after they died in a hospital, that 10% of these patients on autopsy actually had pulmonary emboli. And of those, not of those, but also in the same study, 83% of these patients that had passed away in the hospital actually had DVTs. My assumption is that it probably came from a comatose type lifestyle, where you're just not getting around, you're not moving your legs, and therefore causing blood clots to occur in the legs, breaking off, and eventually then going to the lungs or pulmonary emboli. Another fact I'd like to throw out at you is that heparin is the primary material given from a pharmaceutical therapeutic standpoint to treat DVTs, as well as PE. This is a great thing to know. However, what I want to spin at you is that in 5% of all patients that actually get this type of anticoagulant, that sometimes we get serious internal bleeding, and which would be indicated by a drop in the patient's hematocrit level. So while we want to treat these patients with concerns of PE, it's probably also important to realize that we really only want to treat them if there is high probability for disease. Lung, which we're going to look at first, there are three ways that I would assess that we can actually look at them, and that is with xenon ventilation or 133 xenon, DTP aerosol, and there's a third one which I really will not discuss in any detail, but is technetium-99m technogas. And technogas actually is our friends from down in Australia have developed. Has not been approved in the United States for routine use. But the big difference between DTPA and technogas versus xenon is xenon, we generally only use one image because you're doing a series of different images in this one image. It's usually posterior. As you can see here, it's 80 keV. And there's something referred to as washout. You also need a negative pressured room, which I'll talk about in a little bit. So DTPA and technogas do not need negative pressured room, so that makes it to our advantage. DTPA actually is liquid droplets that are administered via a nebulizer, and they reach down to the alveoli. And then we have technogas, which actually is a graphite wrapped technetium atom. And if you want more information, you're more than welcome to visit this website down here. It's towards the end of actually a website that I have actually produced. So let's talk about the xenon 133 procedure. A patient needs to be usually in the supine position with the FOV or the field of view to include the entire lung field. I suggest a 128 by 128 matrix, a low energy, high resolution collimator, and you're going to dose the patient between 5 and 20 millicuries or 200 to 750 megabecquerels of xenon. I also suggest that we do ventilation before perfusion, and I'll discuss that in a moment as to why that is, but that also I think is a critical factor. You start off with ventilation, you then do perfusion, and the perfusion meaning the MAA. There are three portions to this exam. There's something referred to as the initial breath, which the patient inhales and holds their breath for 20 to 30 seconds. We then go into equilibration, which is 1 to 2 minutes at 60 seconds a frame. And then we go into washout, which is 1 minute per image until all the activity washes out of the lungs. It should be noted that the patient has COPD. The issue then becomes that sometimes that xenon that gets in, remember it's an inert gas, then has to get out. And then if there's mucus in the way, if there's fluid in the way, if there's fibrosis in the way, that then causes the xenon to take longer to exit out of the lung, as well as really to get into the lung. So as I indicated before, why ventilation first? Well, if you look at xenon at 70 keV and you look at technetium at 140 keV, one needs to appreciate the fact that if you did technetium first, then you would have Compton scatter spilling in to the xenon window, which would actually be interfering with the xenon 133. So in order to prevent this scatter radiation spilling in to the xenon window, you do xenon first, then you follow it up with technetium 99M MAA. How do we apply xenon? Well, with xenon, we have something called a xenon gun, or the company calls it a Calidose dispenser. You can see this little guy right here. It has a plunger. You put and we'll click here, we'll actually look at the schematics. You put a vial of xenon in here. There's a metal piercing portion here that pierces the rubber stopper when you push down on it. And then it goes into what we refer to as a spirometer, which is the actual ventilation unit that's going to dispense the xenon to the patient. Once you penetrate the spirometer, and you push down the plunger, you then pump the gas as you tell the patient to inhale. And that starts the initial breath. From here, we have kind of a schematic again of what actually goes on. So remember, initial breath, they're just holding their breath. Then we go into the equilibration phase. Equilibration phase means we're equilibrating the xenon within the lung cavity, as well as it going out into the capillaries and actually into the human body. The red arrows show the indication of equilibration. We also call this a closed system because xenon stays there. It doesn't, no more xenon is introduced, no xenon gets out. So it's a closed system during equilibration. So when the patient exhales, it goes through a biofilter. It then goes into the anhydrous. It goes into what I call sodium lime. The sodium lime, as you see down here, it absorbs the CO2, prevents acidosis. From there, it goes to what I refer to as anhydrous crystals, which are actually blue that slowly turn pink as they absorb the moisture. And then that exits around, goes into a big drum or into a big airbag, and collects the xenon. Along with that, we dump in more oxygen. And then the patient inhales again and exhales, and it goes through the red loops as we see here with the arrows, and it goes around and around until the end of equilibration. Then under washout, as we see up here, now what we do is we add the blue arrow. So it goes down when they exhale, it goes through the red arrow into the sodium lime, into the anhydrous, and then out to a charcoal filter that captures the xenon. And then from there, it goes out to an exhaust. When they inhale what's in here. Again, oxygen is coming in. And the idea is that they're slowly washing out that xenon. So the xenon is no longer circulating through the body. In that process, again, we refer to this as washout. Washout should probably last 3 to 4 minutes if the patient does not have COPD, as I indicated earlier. If they do have COPD, then that translates to it being trapped longer in the lungs. So if you see xenon trapping in the lungs after 3 to 4 minutes, and they're not really getting out, then that indicates that we need to, keep them on the ventilator, or I should say on the xenon machine here, until they actually drop out and no longer have any activity in their lungs. Here are 2 examples of the unit. This is the more common one, and is more readily available. It has a simple control panel. Again, inside here is a big bag where it collects the xenon and you add oxygen. And over here we control between the initial breath, equilibration followed by the washout. The more sophisticated unit is seen here, and we can actually see a breakdown a little bit more of what actually goes on. You have your sodium lime crystals here. You've got your chamber in here. You've got oxygen coming in to add to the chamber. Here's an arm that swings out where the patient then is actually inhaling and exhaling the xenon gas with a mouthpiece. So this is the closed, and this is the inside of it. When it goes to washout, it actually then enters the open system, and it actually goes through the filter and then goes out the building. This is a xenon monitoring the trap to make sure that the xenon coming out, there is no xenon escaping, because if there is, that means the filter is saturated and it needs to be changed. Several other factors about xenon 133, which I'm assuming most of you probably are not going to be utilizing, but I think it's a critical issue that we need to discuss in case xenon is actually utilized in your institution. And the first thing is that if you're doing xenon, you have to have a negative pressured room, which means then you have to calculate the actual amount of time it takes for the air to turn over in the room. That is 100% turnover, as I have here. Why? If the patient rips off their mask and says, I can't breathe, and I can't breathe, when they exhale, xenon's flying through the room. You need to close that door. You need to make sure the ventilation system is working. You need to let that gas escape. How long does that take? That's something that you need to determine. Likewise, usually on a quarterly basis, that is 4 times a year, you should actually evaluate the actual input and output of air going into that room so that you can calculate the actual amount of air, how long it takes for that air exchange to occur. If you have those values and numbers, you're more than welcome to click this website right here. It'll give you more of that information. You can actually type in the numbers for the input and the output. It tells you how long the airflow will take to exchange at 100%. Again, I indicated earlier, anhydrous crystals, they are blue initially. When they absorb moisture, they slowly turn pink. When they all turn pink, it's time to exchange those crystals with new ones, and they need to be replaced so that you continue to not have moisture within the system. And then, of course, during washout, please realize that, if there's still xenon gas in the lungs, then you need to wait and not disconnect them until they have exhaled all that out of their lungs and captured by the charcoal filter. Here's an example of a normal xenon ventilation scan. This over here is the mouthpiece, or I should really say the oral cavity. You see this is initial breath. We go through equilibration. So we have a 1-minute equilibration. And then we go through washout. Each washout is 1 minute. And if you go down to like washout number 4 and 5, I should say really 5 and 6, you can see that there's a little bit of retention, indicating there is a little bit of COPD. Therefore, you really need to keep this patient on a little bit longer, again, until they exhale out the xenon. So now let's talk about DTP aerosol, a slightly different animal. Again, in this scenario here, instead of just doing the posterior image, you can take all the different angles that you need or required, and which is a good thing. So you can really match up that defect. If you see a defect on an LPO or an anterior, you can match that it's cold in ventilation. I'm sorry, it's cold in perfusion and it's hot in ventilation. We're going to do a 128 or 256 matrix, again, a high resolution collimator. You're probably going to give somewhere between 25 and 35 millicuries or 900 to 1300 megabecquerels of technetium DTPA. That's going to be injected in here into the port. It's then going to reside in the nebulizer. The patient should be sitting upright. Again, the FOV covering the entire lung. You want to clamp the nose, put on the mouthpiece here, have them inhale, exhale, and you want to crank up your oxygen port, which the oxygen is coming in here, preferably to around 10 liters per minute. Just a warning, when you get up that high, sometimes the connector on the end of where the oxygen is coming in tends to pop out. So make sure that's nice and secure. You're going to nebulize the patient for 5 minutes, or if you have the opportunity, if your camera allows, you want to read the actual counts coming off the lungs and stop at 3K per second. If not, then go for no more than 5 minutes. Once you're done with that, your critical images are anterior, posterior, left posterior, and right posterior obliques. And if you want to do the other 4, you can also do that. You acquire for about 150K counts per image. Once completed, you obviously can then go on to your perfusion scan. Here's an example of another aerosol system. It's basically the same. You've got your oxygen coming in here. You have your nebulizer. It's going to cause the swirling of the liquid to convert it into little fine droplets. Here's the injector in this scenario here. Here you only have 1 tube, not 2, but it's going in and out. So it's when the patient inhales, it's going this way, and when they exhale, it's going in that direction. And here you have a nice filter to trap any droplets that might be exhaled from the lung. And of course, here you have the shield to protect us, the technologist. One other caveat also is if you do a ventilator patient, which I've done a few in my lifetime, you need to make sure that the whole system stays closed. So here I have an example of the actual unit itself. That is the nebulizer, the filter, and the tubing. But what we do here is we add a tail. And that tail then connects to here. And then from there, as the patient inhales and exhales via the assistance or help with the ventilator, it then actually then goes in and out of the lungs, making sure that this whole unit here is all closed so that you can send that positive pressure into the lungs, allowing the patient to exchange their oxygen with carbon dioxide. So getting the right droplet, here are a couple of things to kind of throw out at you to make sure that you have a better ventilation scan from a droplet standpoint. First of all, you're going to shoot for somewhere around 0.22 microns. The tubing itself that is connected to the actual nebulizer unit will probably filter out the large droplets, 10 to 15 microns. They get trapped there. Whereas in the filter, we'll trap everything that comes back through the filter as a patient exhale, unless it's smaller than 0.1 microns in size. The nebulizer should have between 3 to 5 ml of solution, 3 to 5 ml, not less, not more. Again, we want to maximize the best droplet size of 0.22. The next thing is you want to, again, remember, we want to do 10 liters per minute. You don't want to go 4 or 5. You want to crank that up to about 10. That gives you a really great small droplet size. You want to you want to dose the patient for no more than 5 minutes. The goal is to make sure that you have a 3-to-1 ratio of MAA to DTPA, and I'll talk about that very, very shortly. And finally, one of the things that is rather surprising is this suggestion here. If you look at the end of the references of this talk, you'll find that there's an article that was published, I think back in I want to say 1978 or 1982, somewhere around there, where you also give 10% ethanol mixed in with your saline, mixed in with your technetium, DTPA, to do two things: reduce the surface tension of the droplet and increase the density of the droplet, which then gives you better distribution of that droplet actually getting down into the alveoli. Here's an example of xenon versus aerosol. And what we can see here is that we can actually see anterior, posterior. This is a lot more solid. This is the equilibration phase. And it's kind of odd that we actually have a posterior, which is what we want, xenon, and also we have anterior as well. I'm assuming that what they've done here is to put an anterior and posterior camera together with a patient sitting upright. Here you can see a little bit of difference in distribution. There's a little more clumping of the particles. Here you have stomach down here. Sometimes you'll see main stem bronchi that'll appear here, which you don't want, which is the particles are getting trapped by a lot of fluid or mucus that's actually in the main stem. And then, of course, not only that, you can sometimes see the stomach because the patient is swallowing the actual DTPA and it's going down into their stomach. And here's a better example of showing the main stem bronchi. If you give the 10% ethanol, theoretically that will reduce the amount of clumping of droplets in the main stem. And then secondly, if the patient is a ventilator, it's probably good to suction the patient before you start the procedure to, again, better reduce the amount of central deposition. Because think about this for a moment. You know, what you want to see are lungs. You don't want to see main stem bronchi, right? So your counts are also coming from this area here, which you don't want. So the fewer counts you have there, the better definition and information you're going to get from the right and the left lung. Again, another example of aerosol. Here we have xenon. We have an initial breath. We got washout. Here we have DTP aerosol. And again, we got anterior and posterior. So as earlier, I talked about the 3-to-1 ratio. This is, in my opinion, in some ways, critically important because technetium MAA and technetium DTPA are both the same agent, that is the same radionuclide. Therefore, they both give off the same 140 keV gamma, correct? Bingo. So in order to make sure that my DTPA doesn't shine through that cold spot from the PE when we give MAA, we need to make sure that we have a significant ratio between the amount of activity of MAA and the amount of activity in DTPA. So by definition, 3 times the amount minimum, 4 would actually be even better, but I'm going with a minimum of 3. So we make this classical error mistake. And we say that if you're doing counts per second and you realize that you've got 1750 counts per second coming off of the DTPA, and you multiply that by 3 with the MAA saying, okay, I need at least 3 times that amount, then that means when I inject my MAA, I should see at least 8250 counts per second. But the problem is, of that 8250 to 2750 is the background of your DTPA. So now I'm going to subtract that from my total counts from my MAA, and now I end up with 5,500 MAA counts. When I do the ratio, I have 2 to 1. Not good. Again, concern, shine through. If you've got cold in perfusion, hot in ventilation, and too much activity coming through in ventilation, you might hide that PE. So when you think about this quality control step, you want to make sure that you have that 1850, add 2750 for the background. That gives you a total of 11,270. When you subtract the DTPA of 1750 from that, we end up with 8220. And when we do the ratio, we end up with a 3-to-1. Bingo, we're good to go. And I can also assure you that probably in my technical experience, that when I inject MAA, you know, I'll see 12,000, 14,000, 15,000 counts per second in a 4 to 5 millicurie dose. That being noted, if you cannot count the counts per second when you're administering the DTP aerosol, do not go over 5 minutes. If you drain that nebulizer dry, then you're going to have a lot more counts from the ventilation in the lung which possibly could have shined through on a cold PE defect, which therefore you're going to miss, and you're going to end up with a false negative scan. The other calculation that I love to really evaluate here is to realize that, when we inject the patient with MAA, we're blocking off somewhere between 1 to every 1,000 to 1 in every 10,000 arterials. All right. So we're not blocking, we're blocking very, 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 very few. But let's take a look at a couple other angles here. When you make your MAA and you wait and you inject it 7 hours later, 8 hours later, you go beyond that expiration time, then you're going to be injecting more particles into that patient. So let's take a look at the physiology behind this. First of all, the acceptable range of particles, 10 to 20, is size of the particle should be between 10 and 90 microns at 90%, nothing greater than 150 at 10%. The capillary diameter is 7 to 8 microns. Therefore, we can conclude that we're blocking somewhere towards the terminal end of the arterial, but probably not quite there. Again, as I noted, we're going to block probably on the average about 1 in every 1,000. It could be actually up to 10,000. We want to give somewhere in the neighborhood of 200 to 700,000 particles. That is perfect. So how does decay factor into the equation? Well, I asked you to look at the calculation here. And what I have done is I've said that you've got a dose that contains 8 millicuries per ml. That is the MAA. So 40 millicuries in 5 ml comes out to 8 millicuries per ml. I want to dose the patient with 4 millicuries. So 4 divided by 8 is 0.5. So 0.5 ml. So what happens if I have 6 million particles in that vial? Well, 6 million particles divided by 5 means that I'm giving 1.2 times 10 to the 6 particles per ml, which means then if I inject 0.5 ml, so 0.5 times 1.2 times 10 to the 6 is 600,000 particles. This would be at 7 a.m. in the morning. Now, let's go forward in the future and say, oh, it's 3 o'clock in the afternoon. I've got another lung scan. It came in. I'm going to inject that patient. So what happens here? Well, we go over here, 8 millicuries per ml at 7 a.m. has a decay factor of 0.398. We multiply that by 8 millicuries. We end up with 3.2 millicuries per ml in that MAA vial. Now I take 4 millicurie dose divided by 3.2. I now come up with 1.25 ml of solution that I need to pull off my MAA vial. If I have 1.2 times 10 to the 6 particles and I multiply by 1.25 ml, I'm injecting 1,500 particles, 1,500 K particles, or 1.5 million particles into that patient, which more than doubles the theoretical amount that I should give. So again, critical in what I'm trying to demonstrate here is that the longer you wait after you've made that vial of MAA, the more particles you're going to give. And at some point, you may actually overgo that threshold, and which is a concern. PILPED. Just a brief discussion, very, very brief discussion. We're not here to diagnose disease, but we're here to talk about high probability, intermediate probability, low probability, and normal. So in a ventilation perfusion lung scan, we talk about it in probability. We don't say that, yes, they have PE or no, they don't have PE. We say it's highly probable or lower degree, depending on where all this falls in on. So as you notice here, if you have 2 large mismatched defects, perfusion defects, that is perfusion to ventilation or similar, then you know that you have a very high probability of having PE. Intermediate, you have 1 to 2, preferably more towards the 1 moderate large mismatch with similar combination, negative for chest x-ray. Now you're coming down to the intermediate. Low probability, no segmental perfusion defects. And then of course, normal, meaning no defects, normal looking chest x-ray, normal looking ventilation, normal looking perfusion scan, we're good to go. What you don't want to do, just from a physician standpoint, just as an FYI, is you don't want to fall into the intermediate range if that's at all possible. Because intermediate means you don't know. Do I give heparin? Do I not give heparin? I'm intermediate. Well, now the patient has to go off and have CT or has some of the procedure, perhaps an angio, fluoro, pulmonary fluoroscopy, something of that nature, to further evaluate the patient. And on top of that, what if they're allergic to that contrast, or what if their kidneys are compromised? So it's really, in my opinion, critically important to fall either in the high prob, low prob, or normal, and if at all possible, stay away from intermediate probability. So the the lung perfusion procedure with MAA. Again, high resolution collimator, 140 keV, 20% window, 4 to 5 millicuries given IV. You want to make sure the patient is in the supine position. After you inject, you tell them to also take a couple of deep breaths. Do not flush the syringe with the patient's blood. If you do, you get little clots that can form. They spin around, they sort of form like a small clot along with the particles with the blood, and you end up seeing these hot defects as we see here in this image. You want to do a 256 by 256 matrix, minor typo there. No, that's right, looks good. 500K images or 5 minutes, whichever comes first. There's the typo, not ton, but two. And then we go anterior, posterior, LPO, RPO. We're repeating the exact same images that we took before with the ventilation. If you want to add the other 4 images, you're more than welcome to. All perfusion images must match the same angle of the ventilation. You don't want them to be slightly off. They need to be exactly the same. As far as a chest x-ray is concerned, you want to have a chest x-ray either right after they've had the ventilation perfusion lung, right before, but you go up to 24 hours prior to the lung scan. After that, usually an additional chest x-ray is required. And the chest x-ray will also help us identify whether or not there are some other defects like infiltrates into the lungs, which actually would appear probably as a matched defect in your ventilation perfusion lung scan. Role of gravity. So remember I said before the patient needs to be hopefully I didn't, I did say supine position. You don't want them in the upright position. And the reason for that is that gravity plays a role in the MAA distribution. So essentially, if patient is sitting upright and you inject MAA, there's greater airspace in the apex up here, right, in the apex, and there's greater blood flow in the base, which means then the particles are going to greater gravitate to the base and less to the apex. It is for this reason that it is critically important the patient be in the supine position. And then the other angle too, if you're going to do a straight stick, which I do not recommend, then you don't want to flush the syringe. Here's an example of what a normal perfusion lung scan looks like. What I've done is I've broken up these lobes into their appropriate segments to give you an idea what that looks like. So again, remember we talk about segmental defects with PE. Usually PE blocks one of these segments, and that's what we actually see when you see some type of segmental defect from the perfusion image. I go into this, but I want to discuss this briefly with you because occasionally you're going to run into a patient that might have to have a lung scan, but there are 3 reasons why you need to reduce the amount of particles that you inject into the patient. Number 1 is pediatric. Number 2 is pulmonary hypertension. And number 3 is if the patient has 1 lung. And actually,
correction in the slide here, it should be 75 to 100 K particles for a pediatric dose.
And then 100 to 150 for pulmonary hypertension. Again, 150 to 200 for a patient who has a single lung. And what I offer to you, because it really takes a lot of explanation, but there's a worksheet that you click here that explains all the little parameters you have to fill in here. And then you have a blank worksheet. If you decide that you need to do this, you can click that as well. When you go to the worksheet, where the worksheet explains, when you hover your mouse over this individual areas where the blue is, it'll actually pop in the values so that you can actually see what they are. In the end, what this will do is, depending on the dose that you're going to give the patient and the amount of particles you're going to administer to the patient, it will actually identify, it'll tell you how much saline to add to the solution to a separate vial to give you the appropriate particulate dose. So here's a normal lung scan. Again, we have our 4 views. I don't see any perfusion defects here. Over here, if we look, we can also note that here we have normal distribution of radionuclide with possibly some actual, just a little bit of COPD with some retention going on. I love this picture. This is another really great one. So here we have a patient that actually has pulmonary emboli, pre and post therapy. So does therapy really work? Well, yes, it does. If you look here, here's the initial breath. They did a 1 minute and a 2 minute equilibration, and then they went to washout. Then they did MAA, and look what we have here: chunk missing, chunk missing, chunk missing, chunk missing, chunk missing. You know, you've got defects here. You've got cold in perfusion, hot in ventilation. So the patient goes off, has their anticoagulant, and then they return. And when they return, compare the images. As you can see, the defects are now gone. Let's look at anterior. Where's the anterior? Here you had a sort of a chunk and a chunk. Looks nice. There's no rat bites or anything like that here. Let's go RPO, RPO, RPO. So we got rat bite, rat bite, rat bite, RPO. Looks good to me. So again, this is an example of where therapy does a good job. The anticoagulants dissolve the clot, everything returned to normal. One other thought too about this: if you ever have a pre and post therapy that you want to assess, if you've already done xenon or you've already done DTP aerosol, there's probably no reason to repeat that because you already have the underlying data, the ventilation portion of the scan. All you need to do is repeat the perfusion part, the MAA, unless I would assume if something severely happened ventilation-wise, which you required further analysis. But as a general rule, there's no reason to repeat the ventilation. Here we have an abnormal scan. We have xenon. Now this is abnormal for a different reason. We have a matched defect here. If you look here, you've got your initial breath. It goes into equilibration, and then they go into washout, and you have this big hot spot here. Here's where the xenon has got trapped and it's still trying to get out of the lungs. There's a big, probably a big fungal or bacterial infection going on in the base of that lung. And it is a match defect, which has nothing to do with PE, right? But again, a very interesting case study to actually evaluate. We have DTP aerosol, great example. This patient here does have COPD. You can see the clumping of the ventilation over here. I guess since I started, I'll go here first. So here you see the perfusion, here you see the ventilation. And what we're actually noting here is that the ventilation has a lot of activity missing. Actually, it looks like we've got a lot of clumping of those aerosol droplets in the lung. I sometimes refer to this like as a hot grate phenomenon, but you won't find that in the literature. But if you look down here, it pretty much fills in. We come over here on the left side of the lung, it pretty much fills in perfusion. So, you know, when we look at these images, we can see that there is definitely some COPD going on, but you can also see how the COPD sort of interferes a little bit with the diagnosis of the perfusion scan. So we're looking for significant mismatch defects, which we theoretically do not see. I mean, you could argue, well, that's a mismatch, but it sort of fills in here and it definitely doesn't fill in here. On the flip side, if we want to look at pulmonary emboli, again, we have a ventilation lung scan that ventilation got some cold spots in here. So we got some COPD going on, probably a 30-year smoker. And yet here we go, perfusion, we got this huge, big defect here. It fills in. We've got this huge defect here. It fills in, you know, again, mismatch, perfusion, defect, pulmonary emboli. Again, here we go. Notice I want to start off with the aerosol ventilation with DTPA, main stem bronchi uptake, which again, we don't really want to see if we can all help it. But the lungs look pretty healthy. I don't see a lot of clumping of the particles per se. But if I come over here, it looks like, look, RPO, there's a chunk there. It sort of fills in, right? Let's go posterior. We got defect here, defect here. Looks like it pretty much fills in on the ventilation. Look at the LPO, wow. Cold, maybe over here. Again, nice ventilation. We have pulmonary emboli. Another DTPA aerosol with ventilation. and then MAA perfusion. Again, what do we see here? We see perfusion defect. We have the apex of the lung actually missing. It fills in, right? And we have that defect there. It might sort of match defect there, but we definitely have a portion of the lung missing. We come over here, RPO, and again, missing. It fills in. Here we have sort of filling in here. We definitely have a wedge defect there. Again, pulmonary emboli can be diagnosed. So other facts about PE that you may or may not know. Generally speaking, 90% of the time, there is more than one, it's multiple. 85% of the time, they're bilateral. They tend to appear more at the base. Consider circulation. Patient sitting upright. Where's the circulation? It's more at the base. It tends to be that wedge-shaped defect as a general rule. Remember that we've got those segmental portions of the lung that I showed you earlier when I drew out those little red outlines for you in an earlier slide. The larger the defect, the higher the probability of PE, not PET, but PE. PE can also affect the entire lung, but that's unusual, although I've actually seen one in my experience. More likely, though, if there's an entire lung missing, there may be a tumor pressing up against the bronchial and the pulmonary, preventing blood from actually going in and air from going in. As a result, you get a match defect. But I've seen a mismatch defect in this scenario where actually it was PE. Chest X-ray can show underlying diseases. I think I indicated that earlier. Recent onset of PE, less than 6 hours, may show a defect. And this is actually due to what we refer to as bronchoconstriction, because the lungs spasm right after that happens. And of course, we have lots of different things that can be symptomatic for PE, anything from reduced PO2, which is significant. We could have a DVT, dyspnea, coughing, pleurisy, chest pain, tachycardia, and of course, postpartum. Here's an example of the Fisher sign going through. And in that Fisher sign, as you can see here, there's actually nothing really wrong with this. The patient probably has CHF. And what's happening is you've got extra fluid in the lungs, and it's pressing down on the lungs, and it's separating the different segments. And as a result, because there's extra fluid here, you have some changes in attenuation. And it looks like, well, gee whiz, is that disease? No, it's just increased attenuation. It has nothing to do with PE. Call a Fisher sign. And of course, I've on a rare occasion, I think I've had like maybe 3 experiences in my lifetime where something really, really, really weird has happened. So I've done the DTPA aerosol, right? And then I inject MAA. And this is what I see. There's no lung. A physician friend of mine who, the first time this happened to him, he was a new doc, newly certified. He freaked out. He called up the central pharmacy and said, the particles broke down. And I said, no, it's a right to left shunt. This is a severe right to left shunt because there's absolutely almost no lung whatsoever appearing. When you have a right to left shunt, the activity goes into the right ventricle, shoots across over the left ventricle because there's a hole in the heart, and then it shoots up the pulmonary and goes out to the entire body, causing other areas of the body that have capillaries, arterioles, and they get trapped. So you end up seeing kidneys. You can see liver and spleen, maybe. In this case, we see spleen. You see a little bit of the brain, and that's hard to see, but I'd say maybe there's a little bit of thyroid there. So the key issue to me, from a radiopharmaceutical standpoint, is okay, well, maybe it was just a poor tag. If it's a poor tag and most of it's protectate and not MAA, then I would see stomach, because stomach picks up a lot of pre-tech. I see no stomach. We have right to left shunt. And here's yet another example of right to left shunt that I pulled up online for you. As you can see here, now we have some of the lungs are actually appearing, a little bit of thyroid. That might be bowel, I'm not sure. Or it also could be liver. We have, again, the brain showing up a little bit, up here. Looks like maybe we're gonna have some salivary and we have kidneys. But the main thing is, do you see stomach? No, you don't. So that's all I have for today. I thank you for listening. Just a little bit of humor. You know, when we compare CT, MRI, ultrasound, and X-ray, nuclear medicine produces a very unusual genetic defect. Thank you for listening, and I hope you have a great day. Take care and goodbye.